A senior professor and senior consultant at Apollo Hospital, and sir is a renowned faculty not only nationally but internationally. And sir has a vast area of expertise. As you can see, Saphenous vein graft interventions are one of the difficult ones with lots of problems, lots of complications, lots of protection device. Sir has already put in the heading. So this is area which very few intervention cardiologists go into. So sir, for this talk we needed somebody, a great expert like him, and so it's my honor and pleasure and genuinely personally grateful, sir, for your kindness to join this session. It's really honor.
Thank you so much, Vimal. You are a great friend, and I'm very happy to be part of this webinar and teaching program. Because we always want to teach people, and we also learn while we are teaching. This is very important in medical practice. That's why it is known as practice. So you learn from every patient and you learn from every lecture. So what I'll talk about is saphenous vein graft angioplasty, current indication, future directions, and what is the role of protection devices and drug-eluting stents. So this is how the patient example, if you can see, this is the bypass patient, native vessel. And when you see the saphenous vein graft, they look differently. And few are occluded, for example, and few are not occluded. So these are how we do coronary angiography in such patients. So my plan of presentation will start like this. What are the coronary angioplasty techniques? Why saphenous vein graft angioplasty required? Why native artery bypass surgery? And what are the protection devices? So coronary angioplasty technique, I'm not going into much details. It will be told later on. But there is some sound here. Am I still audible very well? Am I audible?
Audible, sir.
Okay. So percutaneous coronary intervention, the indications, contraindication, equipment, technique, precaution guide, catheter selection guide. Well, this is not the topic, but I'll still touch upon while we are talking about this. Invasive PCI strategy is indicated for patients with unstable angina who have no serious comorbidity. We all know this, so I'm not skipping few slides. STEMI, primary PCI we do. The topic will come directly, I think. Patients with coronary bypass surgery class 3 and 1-3. When technically feasible, PCI should be performed in patients with early ischemia. Usually within 30 days after bypass surgery, it is recommended to use distal embolic protection devices. These are ESC guidelines, so class 1 and class 2A indications. There is no absolute contraindication of PCI. Vimal is doing a lot of complex cases. We are also doing complex cases. When we started doing angioplasty in 1977, when Andrews Grundzig did, and then the stent came in 1987 with Sigvart, and then drug-eluting stent came in 1993-94. Then later on, drug-eluting stent came in 2003, and then of course we are still progressing and we have to learn each and every day. The topic is saphenous vein graft, but I just want to tell you that there is no major contraindications. The patient is fully conscious because these are for students, so I think DNB students will also enjoy such things because small basic things also. The conscious sedation may be required. Normally we don't give. Vascular access is mostly femoral, but most of the centers now are using radial approach also. Antiplatelet therapy, antithrombotic therapy, GP2B receptor antagonist, they all required as an anticoagulant so that there is no stent thrombosis. Of course, we know the need to do the flushing of guide wire. We are in the ascending aorta, then catheter is then connected to manifold. Guiding catheter is flushed to ensure the airfield system. Guiding catheter should be then filled with. So these are small technical part which people don't normally teach, but they learn while they are practicing in a good hospital setup. So the SVG intervention is a little different. It's an embolic protection device should be deployed mostly, and then I will tell you this. Going to skip, but I'll tell you. Let me come directly to the why saphenous vein graft angioplasty. Coming to the main topic, SVG intervention background. So recurrent angina is common in post-bypass patients mainly due to mid-term graft failure. 50% of saphenous vein graft are severely diseased or occluded by 10-year follow-up. Post-bypass patients represent 20-25% of PCI in contemporary practice. At least one SVG graft in 1/3 of these. So 7% of all PCI actually will require require angioplasty. So 50% of bypass graft is very important. That's why I want to tell you are severely diseased or occluded by 10-year follow-up. Post-bypass patients represent 20-25% of PCI in contemporary practice, and at least one SVG graft in 1/3 of these will be requiring angioplasty. Treatment of diseased saphenous vein graft represents several specific challenges to the interventional cardiologist. Patients are older, sicker than native coronary interventions. Complications including restenosis and distal embolization are much more frequent due to difference in underlying pathology. So if you see the data from 1999, Jack, they showed that 15,000 consecutive hospital admissions. They found that native was if you see the PCI results in hospital mortality was much higher in saphenous vein graft as compared to the native. So these are the data. Saphenous vein graft intervention, the problem is everywhere. You can see that there is a thrombosis mostly and degeneration. This is how they look like when they are diseased and when they have atherosclerosis or degeneration of the graft. So let me tell upon the vein graft atherosclerosis, difference between the atherosclerosis of vein graft versus native CAD. In native coronary artery disease, these are all normally the atherosclerosis is mostly focal, while in graft it is generally multifocal and diffuse. The thin fibrous cap in native CAD, while in graft it is a thick fibrous cap, while in graft it is a thin or no fibrous cap. Lipid element generally isolated from blood pool. Lesions may be stable for years, while here the lesions highly unstable and progress rapidly to total occlusion. This is very important. We should know that if you have 70% stenosis of saphenous vein graft, try to do as early as possible, because this 70% will turn into 99% within few weeks of time. This is how the graft disease progression happens. What are the challenges? This is most important slide of the whole topic. The basic challenges: one is most important, restenosis. Second most important challenge, distal embolization or no reflow when you start attempting angioplasty and putting a stent, and of course disease progression and late graft occlusion. So I will touch upon these three in different way. So coming on to the restenosis, happens, as you can see, I'm talking of SVG intervention restenosis. Once you have done a PCI, put a stent, and after that you have a restenosis. So restenosis, normally it happens not in few cases in native graft, but it is also in saphenous vein that you have to have restenosis. Impact of stents, I'm coming on to this. The first trial, which was published in 1997, of course, New England Journal of Medicine, showed that this was bare metal stent. This showed benefit of stenting, improved procedural success, 92% versus 69%. That means without stenting, 69%. Better event-free survival, but angiographic restenosis was still found to be 37%. Very high restenosis rate when you are using saphenous vein graft, bare metal stent, SAVE trial, 1997, New England Journal of Medicine. So this was one of those trials which has shown 6 months binary stenosis in very PTCS 46%, Palma shot stent 37%, again wall stent 38%, knee stent. You remember these are the earlier bare metal stent. Whosoever started angioplasty, they will know and remember these Palma shots. Now they have become history. And knee stent, if you remember, I think Vimal will remember all those things. So SAVE trial, wins randomized and SVG registries, they have shown very high level of restenosis. What are the strategies to prevent restenosis? We can use covered stents, which is no longer used. I'm talking of historically. People tried covered stent, and of course drug-eluting stents. So Joe stent, symbiotic coronary stent, they were tried because they were large diameter, and they showed that the restenosis were reduced in covered stent. Although nobody is using covered stent at the moment, covered stent is only used for the perforation for complications. Symbiotic early experience, but to cover the whole topic, I would like to still tell that wall stent reduced restenosis by 61%, symbiotic 1 and 2. Coming on to drug-eluting stent, which we are using every day now, no data but there is one only randomized data, but eCipher registry, CQ registry, research registry, Wisdom, Indian perspective. So the eCipher registry showed that restenosis lesions were, and the percentage of there was a severe, the MACE and TLR MI, the 6-month data has showed that there was significant reduction in TLR, target lesion revascularization. This is TLR. MACE is major adverse cardiovascular events. These are DNB students might not be knowing. So MACE is major adverse cardiovascular event. TLR is target lesion revascularization was 1.9% in MI, cardiac stent thrombosis. So eCipher registry was very positive when they are using the drug-eluting stent. So what we are talking about is drug-eluting stents in saphenous vein graft stenosis. I will touch upon the research registry, which is again very important, which has shown that overall 22 lesions, this was published early, and survival free of MACE was 84%, which was quite significant. So they showed that mean follow-up was 12 months. They showed that it was useful, and research in saphenous vein graft, here you can see the survival rate of MACE was quite high when you are using. The research registry, again, to summarize, 113 patients with bypass surgery, BMS was used in 66 patients, sirolimus eluting stent was used in 47 patients, and DES group had 77% reduction in risk of TVR and 63% reduction in MACE. So overall, sirolimus stimulating stent was doing very well, and this was published in CAD in 2004. So this was the only randomized clinical trial, Belgian trial, which has shown that SCS led to marked reduction in angiographic resources in MACE. So we all know this thing, that now that we have no choice, but nobody is using BMS. But again, to theoretically cover the topic, I wanted to tell these slides that we have authentic data which show that drug-eluting stents will behave much better than bare metal stent, even in saphenous vein graft. So second challenge of saphenous vein graft intervention is distal reembolization. This is full of thrombus, degenerative material, and this goes distally and causes no reflow. The whole purpose of doing angioplasty is lost, and therefore we have to have something. So coming on to the role of protection devices, distal protection devices and proximal protection devices, distal embolization, slow flow and no reflow, and this leads to increased MACE and rise in CKMB. So distal embolization is really a big enemy for interventional cardiologists. It can be in acute MI condition, or it can be saphenous vein graft intervention. In acute MI, we normally do aspirate and do the thrombosuction, but in this case, saphenous vein graft, we have to use protection devices. I will tell you how to use it. So despite stenting, the data shows CKMB rise, prediction of mortality. Stenting has not completely solved SVG problem. Stenting has not completely solved SVG problem. And this is WCC's data. They showed that 47% had elevation of CKMB. Periprocedural MI was strongly dependent predictor of late mortality. So SAFER analysis, which was published in something like 2003 or 4, the SAFER analysis showed the strong independent relationship between MI and mortality. If you see in SVG graft, the fact that deaths occurred in short term highly suggestive of cause and effect relationship. GP2B3 receptor antagonists, which are being used regularly, does not help these patients. The SVG problem, if you send the data which is published in 1998, the GP2B versus placebo, they had not caused no significant reduction in complications when you do angioplasty of saphenous vein graft. So GP2B are ruled out. So coming on to the protection devices, two types of protection devices: distal protection devices, which is occlusion and angioaspiration and filter wire, and then proximal occlusion devices. Mostly we are using distal protection devices. Proximal is using devices are a little more cumbersome to use it. So what is how to do it? The proximal balloon occlusion flow reversal system, PercuSurge system, which is being used regularly. This is distal protection devices, consist of 4 components: the guard wire, EZ flater, and microseal adapter and export catheter. And you can see this is how the balloon is inflated distally, and then angioplasty is performed. PercuSurge system, this is the whole system. You can see the syringe, the Medtronic, it's coming from Medtronic. And I will show you how this guide catheter, guard wire, this is the guide wire, and then this is the lesion. You have compliant occlusion balloon, and then you perform the angioplasty, and then you take out the balloon, and this is the procedure is finished by this way. So this is how the embolites are actually trapped by the balloon, and this is how when you remove it, then they do not cause distal embolization. PercuSurge aspirates from SVG, 103 SVG. This is how you can see the histopathological pictures on this. So this is actually occlusion and aspiration. This is another view. How can you see? This is the material of blockage, atherosclerosis, or degenerative material. You put the balloon B, and then C, you inflate the balloon and perform the angioplasty, and then the procedure is finished. SAFER study, which is circulated in Bay Metal, circulation 2002. SAFER analysis, they confirmed the superiority of guard wire versus control, and they found that this was highly significant. No reflow PS value was significantly found to be significant that way. Primary endpoint 30-day MACE. Coming on to the filter devices, I was talking of the balloon. This was the balloon occlusion. Now we are talking of the filter devices, and filter devices are AngioGuard, AccuNet filter wire, and this is strap material, and this is how the various companies are making it. This animation is not working. Okay, it's working. You can see how this is very beautiful animation, and of distal filter wire. This is how you put the device distal to the lesion, and then you perform balloon inflation of the lesion, and then you can see that this filter is strapped. This embolic material is strapped by the filter. You perform the stenting here. and then again there is a distal embolization which is strapped, does not go distally, and then you remove the protection device filter, and this is the nice result you receive. This is the quite good animation for the people to learn how the things work. So insertion, deployment, and TTC, stent, and retrieval. These are three. So AngioGuard from Cordis, Medtronic distal protection devices, Trap, Macnova, various are available. Coming on to the balloon occlusion guard wire with filter, FIRE trial which has compared whether distal balloon or distal filter, which is better. So they have seen that this FIRE study which was published in 2003, they did not find any significant difference. That means both filter wire and guard wire device success, clinical success, distal embolization, and 30-day MACE. MACE means major adverse cardiovascular event. Both all are almost equivalent. So it is all the discretion of the operator and how it is accustomed with the device he can use it. So should all SVG intervention performed with embolic protection? The answer is no. There is a cost involved, and therefore it has to be used with discretion and all that. Distal occlusion guard wire, limitation of distal devices. So prolonged occlusion time may not be tolerated by some patients, limited visualization due to occlusion, but while filter with relatively high crossing profile may not capture small particles, unable to perform complete opposition. So while this is useful because this is trapping all the material, filter may not completely trap all the microns, less than the 100 is left out and unable to. So there are limitations of both, but cannot protect initial crossing phase. This is important. When you're crossing with the wire, though you will still have some embolization which can happen, and cannot protect distal anastomosis disease or interposed side branches. These are small limitations of the distal protection devices. Coming on to the proximal devices, which is a Proxys procedure. I have never used this device, but it is little cumbersome to you, but it's a fantastic idea because what you do is proximally inflate the material and through that device, and through the device you perform the whole angioplasty technique, and then you remove everything and the procedure is finished. This is Proxys procedure, and this is contains a Proxys inflation device, a Proxys catheter, guide wire, contrast material. But I think next time I'll try to use this one also. The Proxys proximal trial, which was St. Jude, coming from St. Jude, 600 patients were used, and they have used proximal study, which is a test arm, control arm. So this is very authenticated, and they have shown the superiority. 30-day MACE lesion amenable to either proximal or distal protection. So this is actually a trial which is proximal trial, a trial which is comparing the distal protection and proximal protection, and they found that distal protection, the incidence of MACE was 11%, while in Proxys it was 6%, and this was significantly difference between this. That means proximal devices are a little superior to distal protection devices, but you have to use it very well. When to use protection devices? Lesion of proximal anastomosis, there is no need. Lesion of very distal anastomosis, there is no need. Lesions of body of the graft. So old graft, degenerated graft, long lesion, 2 or more stent, thrombus, high-grade lesion. This is where you have to use protection devices, and you should know how to use it very well. If you are not fully aware of it, you take help of a colleague who has used it, because finally it is a success. Most important is actually the safety of the patient. Whenever you do angioplasty, I tell you, all the young angioplastics, I always tell safety first, success second. But of course, the combination of safety and success is required for interventional cardiologists. So old graft, degenerated graft, long lesion, 2 or more stent, thrombus, high-grade lesions. Third challenge. So we have covered restenosis, we have covered the no reflow or distal embolization. Now the disease progression and left graft occlusion. This is non-PCI system, which I am telling you that you have to have this another challenge. 6 years outcome SVG versus native vessel PCI. They found that published here non-TLR was found to be little high. So practical implication, if feasible, treat the native vessel. That means if SVG is applying OM or SVG is applying the RCA lesion, and if there is a practical possibility of treating the native vessel, treat the native vessel. Don't just forget about the Saphenous vein graft. This is the practical implication of the study, which is published in 1996. If feasible, treat the native vessel, especially if the graft is even mildly degenerated. But there is another important point which everybody should understand: post-bypass statins. This is a very important trial published long time back in New England Journal of Medicine, 1997. And this found that at 4.3 years, there was both a marked reduction in both angiographic progression and need for repeat revascularization in the patients who were taking statins. Normally, bypass patients do not take statins. I have seen that when they have done bypass, after 2-3 years, they lose the follow-up with a physician or a surgeon or a cardiologist, and they stop medicine. So this was a very important trial. Although they used simvastatin at that time, 40 milligram, and they found that statins high dosage, they reduce the degeneration as well as further requirement of target lesion vascularization in saphenous vein graft. Reducing future events. Clopidogrel, again very important salt which is antiplatelet. It is hardly prescribed by any bypass, post-bypass patient. Normally the people stay only on ecosprin. Capri CABG group published in Circulation, randomized clopidogrel versus aspirin. They found that 36 months clopidogrel reduced cardiovascular event by 25-35%. So the purpose is that you should use combination of clopidogrel and ecosprin should always be used unless there is a contraindication, some bleeding, very elderly population, history of stroke. Otherwise, use as we are using this combination in angioplasty patient, in post-bypass patient also. I'm not talking about SVG intervention, I'm talking about post-bypass patient. We want to have a reduction in overall post-bypass ischemia, use clopidogrel and aspirin both. So finally, what are the indication of current recommendation? Use an embolic protection device whenever feasible. Use a drug-eluting stent. Anticoagulation aspirin plus clopidogrel to all patients. Either heparin or bivalent acceptable antithrombin patients. GP2B3A receptor antagonist for SVG intervention not routinely beneficial. If graft has extensive degeneration or multiple lesions, native coronary approach. If graft has extensive degeneration or multiple lesions, native coronary approach should be strongly considered if feasible. Maximize secondary prevention using high-dose statin and probably lifetime clopidogrel. So this is how you use it. Finally, for the young cardiologist, I want to also introduce Indo-European course on revascularization, which is our conference we start doing, and Dr. Vimal Mehta has also been part of this conference. We have done in Paris, Amsterdam, Zurich and Rome, and this time this was in Paris in George Pompidou Hospital. These are the old things. We did in Iceland, we're trying to do in Iceland later on, but now we are having this program coming up on 15th of December. I would appreciate if the students can join, and registration link will be sent to most of the DNB cardiologists who are based in Delhi. This will be in 15th December in New Delhi. I'll share this to the DNB moderators and Dr. Vimal Mehta, and if they want, they can join this program and event. And thank you very much for this, and I would stop sharing and then we can talk a little.
So, sir. Hello.
Yes.
Am I audible, sir?
Yeah, finished my talk. Yes.
Am I audible?
Yeah, you're audible. Yes, you're audible.
Yes. Okay. So, sir, we have a little bit of. You have some time. We some questions. We would request.
Maybe one or two questions because then I have a meeting again.
Okay.
Basically, I summarize again. So SVG intervention is a challenging job, which is mostly degenerated graft, and here the possibility of no reflow and distal reflow, distal embolization is high. So whenever feasible, try to use a native vessel if you can have the possibility. If not, you have to be very cautious because we don't want a no reflow. That's most important. Drug-eluting stents in most of the cases, clopidogrel aspirin in most of the cases, and of course. There are two types of protection devices: distal protection, which is balloon related, and filter. Two types of distal protection devices. And second is of course proximal, which is more cumbersome. And therefore, protection devices knowledge should be available to most of the students whenever they start doing such angioplasty. And the one thing which I have not done is thrombosuction of the. Sometimes we are not using distal protection devices. We can use a simple thrombosuction wire with the help of a aspirate, and we aspirate out everything. And then, of course, immediately after that, then we do balloon dilatation and further stent implantation.
Gone, sir. Yeah. Sir. Your voice was gone for a few moments. Sir, one or two questions are there. How somebody, for example, somebody saying thrombosuction utility. For example, recently I was doing a graft. This was a young fellow, 45 years. He had CABG. I had done his angiogram and referred him for CABG. But his SVG graft was totally occluded. I mean, it was done recently only, 2-3 months back. Now SVG graft was totally occluded. I did lot of thrombosuction, lot of it, and removed lot of material. but still I could not achieve the flow. So, I mean, lot of thrombus was removed. There was some TIMI1 flow trickle was there, but it was loaded with thrombus and all the chunk, cholesterol and everything. So, how do we approach such patients? Number one, that is one question. And then somebody is saying, how will proximal protection device will protect distal embolization? I mean, we have heard about proximal protection in case of carotid angioplasty and all, MOMA device and all, but how it will be effective in this kind of scenario?
I'm sharing again the slides actually, and I will show you again because this is simple to understand. This is how you can see if I.
Yes.
So this is
device.
You see
Yes.
when you have a this is very good beautiful animation, not animation with the pictures of this. So this is how the first is that you have already put a proximal device here.
Yes, sir.
The flow is actually stopped. So for that particular time there is no flow. So when you are putting the proximal device here, this is completely occluded flow. So you have to do stenting. There is no flow here, blood flow. So when there is no blood flow, there is no embolization, distal embolization. I mean embolization.
Agreed.
So you put this device here, you put a stent, and then when you remove it, then because there is no blood flow, it is stopping completely blood flow. Therefore, there is no embolization.
So you after before you deflate your balloon, you take some catheter and suck out everything which is there.
Right.
That's right, sir.
Yes.
Yes. So you take another catheter which is inbuilt, that is part of the system actually. It comes with the whole device.
Right.
And you have mentioned over a evacuation device.
Right.
So you suck out the whole thing so that there is no embolization.
There's no
So which one is better? Because we are used to filters and all more. So which one is more better?
If you see the proximal, this is a study which is proximal study algorithm. The test time they use the proxy system, which is a proximal whenever possible, and filter or guide wire whenever proxy is not possible. Control arm they have used a filter wire and guide wire whenever possible, and no protection device whenever not possible. They found that the result as such of this trial has shown 30-day maze lesions which are amenable to either proximal or distal protection, both. And if you see the 30-day maze was much low significantly low in proxy device versus distal protection. But as I told you that I have never used proximal protection devices. They are from St. Jude. Overall, the results are better with proximal devices. This is a trial which has shown, but we are not using it. But this is a beautiful because there is absolutely what happens in distal protection devices. The one flaw is that during time of passing the wire, you can still have some. This is what I have shown here. When you are passing the wire, when you are crossing the wire, you may still have some distal embolization. While in proximal, you are using that is also not there. To limit
Plus very small molecules, small particles, less than 100 micron and all, and something which may go beyond the circumference of the protection device.
Right.
So all those things can occur.
Right.
All those things can occur.
Right.
Sir, what about the stents? Which stent you showed about drug-eluting stent? You showed one study which was done, I think 2004. You mentioned. So which stent will you prefer? I mean, because as far as my knowledge goes, people have not convincingly shown that. Obviously, we'll use drug-eluting stent in today's era. But is drug-eluting stent the mainstay for this? Does it really help compared to the native vessels? I mean, what is your experience?
No.
Obviously, I'm again saying that we will always use drug-eluting because they are much more easily available now these days. Bare metals are very rarely used, if at all.
It is absolutely not used, rather, I would say. So this actually, this comparison is only for theoretical purpose. First of all, they showed the superiority of stent in the first slide, and then they showed the superiority of drug-eluting stents over bare metal stent in prevention of restenosis. So stents have to be used always. Yes, stents have to be used.
This was there when there was a lot of cost difference and they were very expensive, 1,25,000, and this was for 30,000-40,000. Then these things were of importance, but these days. Another thing, do you find any role in the, M-guard kind of stent where you have a thin layer of protection layer of PTFE or some material which will embed the thrombus or the material, because these lesions are very rugged. They not only have thrombus, they have lot of raw plaque material, which is macrophages, which is cholesterol crystals and so on, which is the main problem with the which cause lot of distal embolization, and which cannot be tackled because thrombus will dissolve.
That is why
we cannot dissolve the cholesterol.
That is why they earlier used this covered stent. They thought of using the covered stent, which was also preventing some distal embolization and further. But I think there is absolutely no point to discuss that we have to use the stents. We have to use a protection device if possible, or aspiration. Coming to your question, which you said, I wanted to know, was it having a TIMI 1 flow when you started the procedure?
Yes, sir. I'll tell you. Patient came to me with he had a bypass surgery done 3 months back, and he came to me with recurrence of angina. His LVF was 25% when bypass was done. It had improved to 45%. Now it again fell. And now the problem was, at that time I could see a tight stenosis in the distal end of the graft, the distal just above the anastomotic side. But by the time around he wanted 7-10 days to consult the family, he came. By that time the graft was totally occluded.
This is what I was saying. It's a very fast progression of disease. That means when you have to do, and sometimes patients take long time, and this is against their own the body.
Yes. So how I took the patient, in fact, not one time but 2 times, because he was a VVIP patient. There were lots of phone calls for him that you do something about him. So I took this fellow again after 2 weeks of 2 or 3 weeks of first procedure, giving him Plasugal and Ecosprin. However, I didn't give any anticoagulant as such. But again, this thing was totally occluded. I did thrombosuction for almost 40 minutes or so.
But you could cross the wire very well, easily.
Yes, I could cross the wire without any difficulty. The hooking was a little bit of an issue, but not that of...
And there was hardly any flow. Hardly any flow. So
there was no flow at all.
Thrombus, actually, it was a graft degenerative material, and you can't do anything in this patient. You have to live with that, because it's a degenerative material which is quite also stuck to the graft veins, and you can't do anything for this, because if it was TIMI 2 flow or something like that, you could still done a stenting and improve the flow with the after thrombosuction. So I think this patient, was it supplying the OM or RCA, which was?
It was supplying a very major OM. It was a dominant LCX, and it was supplying a very big OM actually. And LED 30 was infarcted because patient already had an NTA wall MI. So whatever supply was there, it was from the to the myocardium.
It was very important to do angioplasty, and this was not successful. I don't think any other thing can help. Such patients will have to live with this occluded. I don't know how was RCA, whether it was collateralizing the left system or not.
Sir, no, there was not much collateral, because it was in any case a small vessel. Small vessel in the sense it was a non-dominant vessel. The gist, I get it, that patient should be intervened. What I regret is I should have insisted on operating him. I could see the TIMI2 flow and a distal, relatively discrete kind of lesion, 10 millimeter lesion or so at the just above the. So if I would have opened it at that point of time, perhaps things would have been a little bit different.
This is very important learning. Try to do as early as possible in saphenous vein graft. After 2 weeks or 3 weeks time, the things can be totally disastrous.
Yes.
Thank you very much.
One more last question. Why distal embolization prevention device not to be done in I don't understand. Why distal embolization prevention device not to be done in ISR and proximal anastomy? I cannot understand the question. Nevertheless, in a distal just before anastomotic site, if lesion is there, then where will you put the filter, sir? Last question.
Sorry, what is it? If it is, you can't put it. That's why there are cases where you can't use distal protection devices, very distal. Then you can't do. Then you have to use the proximal devices. That becomes the
So
standard
dear
indication
student,
for
note all the relevant points sir is saying. If you cannot put distal device, then Proxy's system is the only thing you can use in such a patient. Last question, I saw a female patient, somebody is asking, whose CAB grafts occluded within 3 days. PCA was done and again within a week graft was occluded again. I feel the answer is that perhaps the grafts are put in a vessel which was not having much stenosis. If you put a graft in, if native vessel does not have sigmoid stenosis, then graft will occlude again and again.
Right.
So your comments.
So native angioplasty should be done in that patient.
Yes,
if possible.
Because I have seen, why sir? Because you have to have certain flow across any vessel. People have characterized the ml per minute or ml per minute or so flow that is required so as to prevent the occlusion. If there is no flow, then because always the flow will blood flow will occur through the natural vessel, natural artery. Is it so, sir?
Yes, perfect. This is a good answer. So actually, if you have a competitive flow, then the graft will occlude.
Competitive flow. If there is a competitive flow, there are two distinct. So that is why you have to have a real unnecessary grafting is not going to help in a patient. And as you rightly said, you should intervene on the native vessel. That should be given number one preference. Putting a just unnecessary graft in a 50-60% lesion is not going to help. And what about the antiplatelet? How long do you give, sir? You give for a long time, more than 12 months, or you give for a lesser duration?
No, in saphenous vein graft intervention, the antiplatelet has to be almost lifelong. This is what I feel. Unless there is contraindication coming in between, while on the story of after 3 years he has got some bleeding or some stroke or something else which prevents you to do it. I would like to do almost dual antiplatelet for at least 3 years. At least 3 years, and then switch to the 1 year.
And one last, do you do post and dilatation? Some people are of the opinion, do not do post and dilatation once you have deployed the stent, because it will churn out the material from the that jolly kind of thing, that mesh stent.
I think it should be avoided.
It will come out.
It should be avoided. You have to use a very important thing is proper sizing of the stent. If it is 4 millimeter required, use 4 millimeter. Do not because then of course you will be requiring actually post and dilatation mostly when you have very thick plaque or so, or hard plaque or but which is not normally case in saphenous vein graft. But if you have undersized it, then you will think okay. So try to be at least. I always use, for example, if the QCA is showing 3.25, I will use 3.5, because if you do IVAS, it will be slightly overestimation. That means the QCA is doing underestimation. Of course, ball eye should not be do. In saphenous vein graft, don't try to use only ball eye system. Try to do QCA, and most of the cath lab have a QCA system.
Okay, and and what is the pressure? Because I typically deploy in a native vessel stent at 18-19 atmospheres. Here, because it is a muscle, it is all supported. Here, it's a vein. So, what is the appropriate pressure, sir?
I don't think any pressure. There is no contraindication to using high pressure. I normally use at 14 atmospheres mostly.
Okay.
If the stent is fully deployed, I will use at 14 atmosphere, not 18.
And so your point is very clear. Choose the appropriate. Do not undersize the stent. Otherwise, you will not like the lesion. You feel it is underexpanded. You will post-dilated, and you will end up in trouble.
Yes.
So with that, perhaps we can end over here, sir.
Thank you very much. It was a nice opportunity given by yourself, and I am very thankful to Vimal, Mehta and National Board for giving the opportunity. Although I am not using my own office system, but still I could do it. I could do it, and I am very happy that I could do it despite having so much limitations. But I requested initially for 7:30. We are open for another lecture sometime later on some other topic, maybe TAVI or something like that.
Yes. We would love that, sir. So with that, we will end today's session.